want to introduce, while we're doing that, Miss Glenna Crooks. She is one of the most influential, and I really have to say, the most organized people I've ever met. And it's a person that you have to meet and you have to know. She will be leading this fearless discussion, and we are Skyping in a special guest for this next. So, I will leave it to you, Glenna. Thanks.
Thank you, Jill, very much. It's such a pleasure to be here. We have planned to have a very exciting session here. I want to begin by introducing Dr. Bruce Leff. He unfortunately was not able to make the trip today. I think he's just as disappointed as we are that he can't be here, but technology allows us to invite him in. And apparently you don't see him yet, but you will in just a minute. Dr. Leff is really important because he is the father of this movement that we will be talking about today. Next, I want to introduce Bruce Greenstein here. Now, Dr. Bruce Leff and Bruce Greenstein, as both named Bruce, make this potentially challenging for a moderator, especially since if I say Bruce Greenstein enough, he will become Bruce Springsteen. So we have agreed to a convention for referring to both of the Bruces on the panel today. Dr. Bruce Leff will be referred to as Dr. Bruce, and we are going to use the other Bruce's email address, which is Health Bruce, and we will refer to him as Health Bruce. Next.
At gmail.com. If you have any questions, just send them on.
I wasn't sure you wanted the whole address put. Then we have joining us today as well, Sung Pobletti. And finally, Richie Rakowski, who is not only pleased to be here to celebrate this panel, but he's also celebrating his birthday. So let's join in wishing a happy birthday.
Thank you.
So to start today, I've asked each one of the panelists to tell a story about what catalyzed their interest in the hospital at home idea, particularly a patient interest. We want to get beyond the sort of usual notion of patient centricity. So Dr. Bruce, I'd like you to start if you would, please. No. Oh, I guess.
Maybe
Okay.
there's someone that knows something about technology in the building.
In that case.
You know how to say that. Sad.
Okay. In that case, Health Bruce, would you please lead off with the story about a patient that catalyzed your interest in hospital at home?
You know what I'm going to do is I'm going to flip the answer around. I have a patient story. It's about my mom. It goes over a number of years. She was a dialysis patient, in and out of the hospital many, many times. But you're going to hear better patient stories from more empathetic people. Not that I'm unempathetic, but I've spent about half of my career in the government, both at HHS in Washington, D.C., and also as the Secretary of Health and Estate. And so when I think about patient stories, I think about them in the numbers that are in the thousands and the millions. So when I think about my last patient story at HHS, I think about the number of patients that we're concerned about that are covered by Medicare and Medicaid specifically. So we're talking about hundreds of millions. And when we talk about the movement of bringing healthcare that could be potentially dangerous in some places, I don't know, is that being censored? When we talk about bringing healthcare into the home, I think about it in a couple of ways. One is around safety, one is around patient preference, and the other is what I was kind of programmed to do is think about, are we going to keep the programs that we run on behalf of the nation, are we going to keep them solvent? Are we going to be able to save money? Are we going to stop being inefficient with our spend? And so when I come to this, I care about patients, I care about my family and all y'all's family, but I really care about making our programs for the government and employer-sponsored health insurance more efficient, more flexible, and giving patients what they want. And that's going to end up benefiting everybody in the healthcare system.
Sung, a patient story from you.
Well, it's a composite story. First of all, I run an organization called Stand Up to Cancer, and our primary goal is to raise significant funds to accelerate cancer research so that we can benefit patients as quickly as possible. And for us, we collaborate with scientists across multiple institutions, but we really try to help patients in their cancer journey. So when you have patients enrolling in clinical trials, you hear stories about all of the barriers that they encounter. One being the time, the cost of time being spent away from their family, their work, and thinking about the fact that you have to have a caregiver who needs to be with the patient to go back and forth from research centers. It's a cost that's very, very heavy on a patient. So when I met Richie and heard about the medically home opportunity, it was a no-brainer. Instead of trying to build processes to help a patient, why not put the patient at the center of care and address their needs? And so for me, it's every cancer patient that I've encountered through clinical trials that makes me realize this is a no-brainer that would help payers, would help pharmaceutical companies, would help patients, and also the scientists.
In addition to the bios that you have in the material provided to you, and I can only imagine a number of you have Googled the panelists already and perhaps linked with them on social media platforms, you're starting to get a sense of who they are. Now, Richie, a story from you.
I'm going to let Bruce go first.
Okay. Dr. Bruce, a story from you about a patient that catalyzed your interest in what you've been doing in the hospital at home movement.
Yeah, so my interest was catalyzed as a clinician. So I started doing hospitals in Baltimore and Johns Hopkins about 30 years ago. And we submitted to, is that getting reverb or is that coming okay?
Getting a little reverb, but you're okay.
Okay. And making house calls to patients in Baltimore, we were struck with two significant situations. One, where older adults were acutely ill and absolutely refused to go to the hospital because they had had terrible experiences in the hospital previously. The other was when in my clinic or making a house call and I have someone who is acutely ill, I get anxious about sending them to the hospital if they are sick because the hospital is really a dangerous environment for them many times where they experience bad outcomes. Things like declines in their ability to function, becoming acutely confused, falling in the hospital. So we thought there has to be a better way, and the idea was to provide hospital care to get better outcomes.
And Richie?
So my story is a very personal one. My dad was being admitted into an academic medical center hospital as I was joining its board. That was about 10 years ago. And I kept a diary of his care to share with the board. And about 3 days into his care, he passed away from consecutive medical errors. I was affiliated with the hospital. It was extremely disturbing. I'm an engineer by background and training. And what occurred to me was a very well-intentioned group of clinicians working hard, trying to make the best care possible, still had that type of system failure. And what I discovered was that about 65% of the cost of delivering care in a hospital is bricks and mortar overhead. And if you do simple math, you're left with about 35% to actually deliver care, which means the hospital is going to be very, very rushed to get the patient out as quickly as possible and has as few as possible touch points to deal with patient care. That led to the idea of virtualizing care and keeping the patient at the preferred site of care, which is home. And all of the work that Dr. Bruce Leff did at Hopkins for 15 years validated that the home is actually a preferred site of care to recover from acute illness. So this has been a very deep personal journey for me, again, about 10 years ago.
I want to come back now to you, Dr. Bruce. I'm not sure if you heard me say at the very early part of the session that you were the father of this movement. I want to go now and ask you to talk in a great deal more detail so that we can level set what people in the audience know about hospital at home care. how patients are selected for it, how the systems were set up, in the research that you've been doing over all of this time.
Yeah, so hospital at home is actually one of the best studied clinical delivery models out there. If you look into the world literature, there are dozens of randomized controlled trials. And what they show is that patients actually do better at home than in the hospital. So you actually have lower mortality rates at home at 6 months after treatment. So basically, you can say to a patient, prefer to be treated at home or in the hospital? Would you like to have a better chance to be alive or not 6 months later? It's a very powerful intervention. If hospital at home were a pill or a medical device, none of us would be sitting up on the stage. We would, be on a beach in the Caymans counting billions of dollars in profit because it's such a powerful intervention. But health service delivery, disseminating health service delivery is more difficult, but certainly worthy of the effort. And in addition to mortality advantage, you'll see improvements in function, lower rate of cognitive decline, all sorts of benefits because of being taken care of at home.
The question I would have, given what you've said, Dr. Bruce, about the importance, the value, and the benefits of hospital care home, is why isn't this better known? Maybe, Richie, I could get you to talk about that a little bit. As someone in the healthcare world myself, as someone who reads the news aggregators every day, who is involved with many people doing innovative work, this idea is relatively new to me, and I'm wondering how I missed it. So perhaps you can talk to that.
Well, it's new. The number of actual patient encounters doing high acuity care at home is still very limited across a very short span of time. So it's new, and sessions like this, sharing this with a broader group, will actually create more awareness. But it's a relatively new intervention for patients at home.
Can I ask then, Health Bruce and Richie, could you both talk about what this really means operationally? I mean, how does it work? Explain if I wound up in the hospital or my mother wound up in the hospital today and was a candidate for this service, what does it really mean from step 1 to 2 to 3 and so on?
So the best way to imagine this, first of all, everyone put on your hat as being a human being, a family member, and not a technologist or a business person. So the goal is you're going to have to take the hospital that's currently centralized in a building and actually deliver it to a patient's home. So the first thing you're going to have to do is turn that home into a temporary virtual hospital unit. You have to monitor that patient, see the patient and their family has to see you, so you have to literally turn the home into a temporary hospital unit as if that remote site was literally right next to the clinicians. So that's the first thing you have to do. The second thing you have to do is take all the clinicians that are attending these patients and centralize them in a medical command center. So think a mission control, like a NASA-like environment where doctors, physicians, nurses, and nurse practitioners are centralized using software and managing patient care remotely. And the last and the most difficult thing you have to do, which is why Bruce Health is on the stage, is you're going to have to take the 18 services that are currently offered to patients in the hospital inside a central location, put them on wheels, and deliver them to the patient's home on demand rapidly and coordinate all that care. So hundreds of encounters have to be mobilized and brought into the home. So centralizing the care in the middle controls the patient's remote environment and all of the services. So a virtual hospital is literally 3 legs of a stool, a wired home, a central command center, and mobilized services brought into the home.
So Health Bruce, Dr. Bruce has described the benefits. Richie has talked about the operations of it. It seems pretty simple. Why isn't this more available in the country? Isn't this an innovation that should be accelerated and disseminated much more rapidly within healthcare today?
So let's bring it back because we are at CES. So there is a major component that is technology related. Let's start at the very basic. Who, when they came in here, knew exactly what hospital at the home means? So a couple people. It's an incredibly heterogeneous definition. It's a program, it sort of sounds like you're talking about, but organizations all across the country that want to do more care in the home and not in a facility have a moniker that they use, whether it's hospital at home or skilled nursing at home or healthcare at home. And then there's myriad companies that are doing something that takes care that used to be done in a place that has bricks and mortar and a lot of people and a lot of things that go beep all the time, and then are doing it at home. So the definition is changing over time, and it's flexible, which is fine, because we want to see more programs that are really customized to what either the patient population or a health system or a health plan wants to do, and it is flexible. We've not heard about it because it's not broadly available. There's not a place where you can, in an ambulance, push a button for the hospital or push a button to turn around, go back around the block and go back to your home. We're at a place in time where technology really matters, and the level of technology, the whole set of kit that goes in the home in Richie's program is incredibly advanced. And if we thought about remote monitoring or telemedicine, most of what we're doing is just face-to-face with some measures of biometric features. But in this case, you have to think about where the nursing station is. When you're in the hospital and there's a nursing station that's monitoring vitals, it doesn't have to be across the hall. In this case, it could be in Boston, and your bed could be in Indianapolis, for example. So we're just getting the point where technology makes sense, it's scalable, it's not super expensive, it's not cheap, but it's affordable, and it's certainly more affordable in the context of providing the care in the home rather than in the hospital. Now, you have to take the next step. Is it safe enough? What's the level of complexity of patients that you'll take in? How do you choose to go there instead of going home? These are programmatic functions that partnerships between hospitals and hospital-at-home programs, health plans and hospital-at-home programs, that will come to fruition. And also I see a ramp period that starts with complex patients that will make the choice and go into a program like this. And it will also begin something that has happened all across the country, all within the last, say, 10 years or so, where more care is happening in the home instead of in a doctor's office. Instead of people recovering after hospitalization in a skilled nursing facility, they come home with a set of services, people coming to their house, technology to monitor them. That's happening today because it's far more efficient from the dollar point of view, and it's safer as well. And that's where people want to go. So we're in the midst of a very quiet revolution. I think it's picking up steam and speed at the same time. And the better that we are at articulating exactly what these programs mean and how it works, the better we are in terms of making it more widely available.
I think you've just explained to me why it's worthwhile then for the CMS Center for Innovation to be doing research on this now. It's because there's not a very clear definition. I'm going to have some other questions for you about current operations and how they work, but I want to come back to Sung now. Because Sung, you said that when you first heard about this, it just made total sense to you. And we hinted in the program notes that this could have implications for research. Can I turn to you now and ask you about this? If we're going to take another daring step in this movement, how does that relate to research?
So when you think about the fact that when patients join clinical trials, they're making a significant contribution to the advancement of science. And obviously scientists are grateful for that. But what the patient goes through for participating in that trial, there's a lot of barriers. For instance, I was talking to a patient who enrolled in a clinical trial, and it's a combinatorial therapy with lots of toxic drugs. You get infused at a medical center, you're feeling nauseous, you're vomiting, you're not feeling well, but now you've got to go from the medical center to the patient's home. And that could be 20 minutes if you're lucky, it could be an hour and a half or 2 hours. And the patient themselves are not the ones that are driving. They have to rely on a family member or a caregiver. So when you think about the context of trying to help a patient get through that, providing transportation, doing all the necessary things to get that patient to follow the protocol and actually stay in a clinical trial, it was maddening for me to work with a team of people to try to have one patient really be taken care of in a way that made sense. When they had a question, they would reach out to their research team. It wasn't necessarily immediate feedback. It could take 20, 30 minutes, but for a cancer patient, that could feel like a lifetime. If you think about the fact that 1 out of 3 people in this country will be diagnosed with cancer in their lifetime, it's quite startling to think, what we can do to advance the therapies so that patients can benefit. And when you put all of that together and start taking apart everything and thinking about, okay, if we could redesign clinical trials and how patients are cared for, what would you do? Eureka. That was my moment when I said, oh my God, what if we brought all of the services to the patient's home? One of the patients that has been tremendously supportive to me personally in moving clinical trials to the patient's home, he passed away about 6 months ago. And for him, he chose not to join a clinical trial because he preferred to be at home with his family. And one of the last things he said to me was, if you were able to launch Medically Home today, I would have been able to participate in a clinical trial surrounded by my family members. And that's something that I'm going to remember.
So you've thought about this idea. Are you planning to pursue it?
I'm sorry.
I said you've thought about this idea, creating an ability for a patient to participate in a trial from their own home. Is this getting? Are you past just the imagination stage? Is this something you're intending to do?
So we have a pilot. We're working with Mass General Hospital, and we have a pilot that has been IRB approved, and we will be enrolling patients in a couple of weeks. So it's not just a dream, it's a reality, and we're really excited. It's incredible when you talk to patients, the amount of time that they can save going to and from medical centers. And the whole technology, as Health Bruce put it, the ability to communicate not only with your oncologist, but your clinical trial team, it really level sets the patient and that safety net that it creates for them. Imagine you're at home, you have a question about a potential symptom that you're feeling. All you have to do is push a button. You've got your nurse who comes on, and you can actually have a direct communication with them. There's no waiting. It's real time.
And I would imagine with the other technologies involved, you can track real-time side effects perhaps and intervene more quickly. You might see side effects a patient doesn't even realize it's a side effect. Might that be the case?
I'm like jumping into this conversation because I'm so excited about it. So with complex therapies, and especially immunotherapies, that has now become the 4th pillar of cancer treatment, we're seeing great responses to the medication, but we're also seeing tremendous side effects. And with these toxic potential side effects, it could mean 30 to 40% of patients that will end up in the hospital for adverse effects. What if we could manage and track these effects before it becomes major and prevent hospitalizations? So this digital health technologies can really allow us to track the patients even more carefully than we could ever do. And if you can prevent that patient from going into the emergency room or the hospital, I think we have a win-win.
Or I would add, from dropping out of the clinical study.
Yeah.
Because I would imagine under circumstances like that, there's a very high dropout rate.
There is. I mean, the whole clinical trials enterprise, 30% of trials that get started don't finish because of accrual reasons. And bringing clinical trials to the patient's home will really increase and address the opportunity for patients from all walks of life to consider participating in trials, and also have the opportunity to not only be a part of the trial, complete the trial, but also be able to follow up for a number of years.
One of the most profound, underappreciated aspects of this technology is the ability to integrate the family 24/7 on demand, and it's usually a family member that struggles not just with cancer care, but other types of very acute illnesses, and they want to access a clinician to ask a question or get the status of their family member. The beauty of the platform is now every family member can be integrated, looped in, ask questions, have them answered on demand in real time, which changes the level of emotional response that a family member has, which then drives typically patient behavior towards the hospital. So getting everyone integrated into the model, getting access to those clinicians in real time is a very, very big deal.
Let me jump in because you bring up a very good point. And there's a piece that we don't typically talk about. I won't ask for hands, but just everyone in the crowd, think if you've had an elderly parent that is either going into the hospital, you suspect they need to go to the hospital, they're having some problems, but you're not in the same town. You're not at the bedside. Right. And so when we think about why people either go back to the hospital after coming home or go to the hospital, whether it's on a 911 call or having an ambulance just called up and sent to the house, it preys upon two things. These are very base emotions. One is anxiety. You have a real concern about this great unknown, unless you're a physician and you have it fully under control. But otherwise, there's a lot going on with your loved one that you can't understand. You don't have the diagnostic tools. And so you go to the hospital as a reaction. The second piece is guilt. Now, we don't talk about it very often, but it's an amazing driver. So if you're feeling guilty and you're feeling without a lot of power and control because you live in another town and your parents are in Del Boca Vista, it's very... That was worth a laugh at least. A Seinfeld reference, come on. It's definitely a driver that makes people make what they see as the most cautious and using the most resources decision, but is rarely the right decision to make. So when you think about, again, intersecting technology and the model, it gives the ability to have distant and remote, could be the children, adult children of the parents, or it could be spouse, it could be anyone in the family, having access to the clinician and information, being part of the care team, even remotely, makes those healthcare decisions, whether they're resource related or clinically related, and makes them far more efficient, far more accurate, and really keeps the family together in making those decisions. I don't want that to be underplayed. Again, it's the anxiety and guilt that gets addressed through technology, telepresence, and answering questions that even when you're in the hospital, I've spent, dozens of days in the hospital and now hundreds of hours waiting for a clinician to answer a simple question about one of my parents in the hospital. And in this case, when you have easy access to both data and clinicians, it becomes a preferable place to get information, reduce anxiety, and make better decisions.
I want to return to the research potential in the future, but I want to start to transition now to how far can we push the envelope. And Health Bruce, I want to dovetail off of something that you've just said, because you've mentioned that your parents may be far away. So let's talk about some of the demographic trends that are kind of below the surface in healthcare today. 14 million people over the age of 65 have no family at all. They're known now as elder orphans. They've survived everyone else and are now on their own. 25 million boomers never had kids. So if they are divorced, if they survive their spouse or they never married, they're destined to be elder orphans potentially themselves. And then your notion of distance is one. I'm going to coin a term here, geographic orphans. 40% of Americans live on average 700 miles away from where they were born and raised. But frankly, even if you live in the same town, it can take an hour to get across town, even if it's not rush hour and there's a lot of traffic. In addition to that, we've got horribly disrupted families. Only 20% of families today are once married couples with children. The rest are either single parent, divorced, blended, remarried families, or increasingly grandparents caring for grandchildren because of opioids. So with the demographic trend like that, and your perspective on families, Richie, you've expressed that already today, as we go beyond where we are right now and use all of this technology available, what else, how will you help in situations like that? Dr. Bruce, you mentioned in your own research that being alone was not necessarily a barrier to somebody receiving care at home. I'm wondering if you have an example of that from a patient.
I'm so sorry, I had trouble hearing some of what you were saying, but it sounds like you were talking about the issue of folks who are alone at home and how this model could potentially be leveraged to help with that.
Yes.
Okay, so one thing I think it's important to think about with everything we've talked about is that at some level, technology, monitoring, think about it as a set of verbs as opposed to a noun. Right? We have this capability to keep people outside of facilities. You can apply it to a bunch of use cases. One is doing medical care in the home instead of the hospital. One is doing clinical trials at home instead of taking people when they come to the hospital. Another would be to leverage this technology to the advantage of folks who are trying to aid in place and create life care. Have the technology, and you could also deploy additional services in addition to the technology to help provide basically community-based long-term care in the home. So, the ability to do these kinds of functions really can create new use cases that can really do society and really help with some demographic issues that are happening in the country.
So Glenn, if I may add, one of the things we've come to take for granted, it began about 40 years ago when we industrialized medicine, was that back in the day there was a clinician that was responsible for our care, and there was an enormous amount of connectivity between the clinician and the patient. Patient was ill, clinician took charge of their care, and through the course of their care there was a moment of healing. Patient completed their care, there was an enormous amount of satisfaction for the clinician having gone through the entire course of care and getting the positive feedback, which clinicians live for. It's the food of a healer. We industrialized medicine, and then we started to do piecework, where one clinician did a piece of the care, another clinician did another piece of the care, and most of the clinicians never got to see what happened at the end of the course of care, whether the patient did well or not. So one of the artifacts of this approach is if you do have a significantly lower cost because of using the patient's home to deliver care, a single care team can stay with the patient from the very beginning to the very end with no handoffs, no transitions, and no loss of satisfaction by the clinician and actually seeing the outcome of their investment in the patient. I cannot overstate how important that is for clinicians, because that's actually why they went into medicine, was to heal patients. So the thing that we hardly ever talk about is by opening up this model and allowing a care team to care for a patient from beginning to a stable endpoint, which is typically between 15 and 30 days, we've changed the dynamic and brought back the healer and the healer dynamic between the patient and the clinician, which is a very, very big deal. And technology enabling that, as opposed to technology substituting for the clinician, is a very, very big and underappreciated point of this approach.
Isn't there, you hinted at something already today though, I'd like you to return to it. Aren't you seeing a healing at the family level, not just at the patient level as well? Can you talk a little bit more about that, and perhaps you have a story?
Yeah, so our first patient, whose name was Chuck, was 92 years old, is now currently 93 years old, cancer, and was admitted with a urinary tract infection, was seriously ill, and was estranged from his family. His roommate, who was 20 years younger than him, was suffering from psychological issues, so we had to manage her while managing him, which was no small challenge. In the event, as this progressed and as Chuck's health improved, we discovered that what Chuck's really wanted to do was to be reunited with his family. So by bringing the family into the care team, we did that. Chuck then was reunited with his children, his grandchildren, his great-grandchildren, At the end of his course of care, we actually were asked by him to move him out from that relationship into a new home, which we did, reunited him with his family, and just recently got a Thanksgiving card from him thanking us. So that's the patient family side. The family sends us flowers and gifts all the time for bringing Chuck back to their lives. But here's the interesting part. The year previous and the year previous to that we saw Chuck, he was the single most expensive patient, most frequently hospitalized patient in the Harvard Vanguard system. And the year since we've had him, he's been the least expensive patient. So separate from patient outcomes, separate from family satisfaction, the economics of this are stunning, and it all came together. And his Thanksgiving card is a very, very big part of why we do what we do.
Well, on stage today, we have quite an array of different talents, and I think some of those same ones in the audience, if you don't mind, we're going to stop and talk about this so that we could, by now, you know a lot more about us, and particularly about our panelists here. We don't know a lot about you. So can I see a show of hands mirroring some people who are here? Any engineers? Okay. Clinical professionals, either medicine, nursing, pharmacy, or other areas? Okay. Research scientists? Okay. Government appointees and regulators? Investors? Okay. Any healers here? Oh, I got a couple of hands go up. That was kind of a trick question. Everyone on this panel sees themselves this way, and this is the way that they look at their work and what they do. I want to ask you now, as healers, coming from the perspective that you have, how far can we go? Let's talk about that. And alongside of that, what do you need in order to make the next bold steps to get where you would like us to be? Health Bruce, can you go first?
So I'll start out as a recovering regulator. I think that, see, that was pretty funny too. I think one of the most powerful tools that we try not to admit that is so powerful is the way that we pay for stuff. Whether it's a medical device, a procedure, an episode of care. Our US healthcare system is so amazingly shaped by the way we pay for medical experiences in the Medicare program. It's transferred across the entire healthcare economy. In the last several years, we started to pay for surgical episodes in a bundle. It's changed that market dramatically. And usually what happens is, as you could imagine, it pushes where high costs in that episode are to lower settings. So for example, instead of a hospital, for simple surgeries, like let's say a knee replacement, sounds simple, probably more complicated, we moved to outpatient surgical centers. Instead of spending a long time of recovering in a skilled nursing facility, we recover in the home. So as we recognize what the potential is to do in the hospital at home movement, we recognize the opportunity to do it safely, and then government payment is not just allowed at the margin, but becomes preferred. Then health plans and health systems, any entity that's at risk for the total cost of care, will then use these tools as a way to go ahead and deliver high quality care. Because at the end of the day, you took care of Chuck, you were probably measured over 90 days, not 1 week, not 30 days at the extent we are today. But the longer that you're responsible for the total cost of care, the more important the decisions that you make up at the beginning of the episode, more they matter. And so I think by placing risk in the right place, by aligning government payment policy, by clarifying what we mean by hospital at home or skilled nursing at home, to create some structure around this, the more that the opportunities get recognized and get applied throughout every level in our healthcare system.
So as a healer, and maybe this is a horrible metaphor, but I'm going to do it anyway, so I'm a big Lady Gaga fan, admitted. And her new movie was amazing. Nobody cares about the number of watts in the amplifiers, the power of the speakers that she uses to do a concert. Nobody cares. What they care about is her voice, her music, her message. So I'm going to try to reduce through the eyes of a healer, and every one of you in this room has a family as a healer. So the first thing you want is you want the person who's taking care of your loved ones to actually care about them. Health care. I care about the person that's now suffering or is in pain or is ill or is vulnerable or is afraid. So do they care? Number two, I need help. I need help now. Would you please answer my questions? Would you please intervene and provide a relief that I need right now? Lastly, most importantly, are you available all the time when I need you? Because I'm sick. I'm not sick some of the time. I'm not sick Monday through Friday, 9 to 5. I'm sick 24 hours a day, 7 days a week. Those very, very basic human needs that are required to be able to be, they're required to be responded to by a healer. We should be using technology to just assume that's what everyone wants, shape the technology to deliver that, as opposed to develop technologies to replace clinicians, develop technologies to just simply think that we're reducing costs. What are the core emotional drivers of a healer and those that we heal, and shape the technologies for that? That sounds like such a simple and obvious idea. It is not. Because when you bring technologists into any kind of healthcare delivery system, there is a bit of a siloing that goes on, and we lose sight of why we're actually doing the technology.
I want to do a quick follow-up question with you, Richie. Do you have a wish list of what those next technology supports could be to either reduce barriers or to improve what you're doing?
I don't think we have a technology issue. I think we have a reimbursement issue, and we have a loss of focus of care. We have brilliant technologists. A lot of them are here in Las Vegas this week. We can literally create any kind of sensor, any kind of low-cost interventional platform, any kind of software. We need to be reimbursed appropriately, per Bruce's point, and we need to actually recognize that we need to care about those patients. That's what we need.
Dr. Bruce, I was going to turn to you, and I'd like to ask you, in addition to whatever other comments you'd like to make, as a clinician, the limits to treating certain things at home. I'm going to use my mom as an example. She had recurrent C. diff and was in the hospital for 10 days, twice, in isolation on IV vancomycin. Could she have been treated at home?
Oh, absolutely. Your mom could have and may have done better at home. And, just to build on Bruce and Richie's comments, I think in addition to pain, I don't think it's a technology gap. I think it's a leadership gap. I think it's a culture change gap, right? Because a lot of healthcare leaders still want to fill beds with patients, right? They understand that they need to change what they're doing, but they really don't know how to do it. They're kind of stuck in what they've been doing for a while. It's kind of like walking into the boardroom of Kodak 30 years ago and saying, you know what, we have this thing called digital photography, and you can change your business model, and they were unable to do that. And that's not unique in that field, right? So healthcare leaders need to be able to change as well, and culture needs to be able to change, and we need to be able to see the home and the community as the next place where care should really be happening. Hospitals are necessary, but hospitals should evolve over time. And I think the future will be large and care unit. Right? It'll be a place where you can get certain procedures, and it's the only place to get them. Everything else should happen in the community.
And so, push the envelope for research. I mean, your heart is in cancer right now, but you're a nurse, and I'm sure you've taken care of a number of people. You're a nurse educator, you've trained other nurses. How else can you imagine going forward in the future? I think about vulnerable populations of all sorts, and people who are not generally included in the clinical trials. Have you given that some consideration as well?
I have. I think, one of the reasons why this model resonates with me and other caregivers is the fact that we're really putting the patient back at the center of care, and the amount of support that you're given. And it goes to Bruce physician's comments that you could be a person who's alone and still benefit and feel like there is that support. And I think that's really important. We're very isolated today with technology, but this is technology that's bringing everyone together. So if you have a family member that's in Idaho or LA and you're based out of Boston, you still have the way to connect everyone so that you can really understand the health status in real time. And that's something that I think we need to really revisit and focus on. That connectivity, that touch is really important, and it's part of the healing process.
Can I just add one thing on here?
Go ahead.
It's, I'm thinking about what Dr. Bruce just said about it's a leadership and culture conundrum. So if any of us out here needed to go to the hospital and we wanted to be at home, you kind of have to live in New York City or live in Boston and be so lucky to be one of the very few people that gets access to this incredible program and benefit. Instead, it's got to come from the change in leadership and the change in culture. We all have to be asking and demanding for it. Dr. Bruce said something, if this was a pill and the results were so good, we wouldn't have any discussion about it. But so we need to think about it like that. And if you're looking for something to end the panel, you know, what's the go-do? What's the take charge here? Is we shouldn't stand for something that we need a campaign and it needs to be a revolution and we need to change the culture. This is something that people should be asking for all the time. And when it has better outcomes and it's less expensive, it shouldn't be that hard to convince people.
We're getting to the wrap-up. I'd like to give each of the panelists about 30 seconds to make any final comments, and particularly in reflection on everything that we've talked about today or where you might want to head on this in the future. Richie, I'm going to start with you.
This has been a long journey for me, and having my birthday today is also quite odd. I guess enamored, as an engineer, I'm enamored with technology. I'm enamored with many systems we've developed to enable our model. But what I'm most enamored about is when I see particularly cancer patients and their caregivers come together and that healing moment happens. It's just that simple word, love. So my final word is don't forget, healthcare is about love. It's not about technology. It should be technology in service of love.
Thank you. Sung?
Well, I wanted to end with a really positive clinical trial patient story. David knows that I'm talking about him. He was one of the first patients to go on immunotherapy, and it cured his lung cancer. And when I asked him about his cancer journey, he said that cancer gave him more than it took from him because he was now part of the cure. And I think we could bring more of these patients through the Medically Home initiative.
Health Bruce.
I'll have a less empathetic story compared to people on the panel. But let me use your birthday as an example, because we are on a journey. And I don't want it to take this long, because maybe it was, I don't know, 35, 40 years when you were born. Maybe it's a little bit longer. But your mom was probably in the hospital 7 to 10 days after she had you. It was normal to stay in the hospital for very long. Think thousands of years while we were being born in caves, we really were doing hospital at home all the time. That's where the deliveries were taking place. But today, when my wife had our kids, you know, everything looks good, fine, baby cries, you're out the next day. So we've moved so quickly in your lifetime from something that was medically accepted and probably demanded, where you stay in the hospital for 7 to 10 days, and now you're there for probably 35, 40 hours at the most. What we're seeing today are recognitions of the capability of medicine to go outside of those four walls where the outcomes can be better and where it will be less expensive. And again, we're all part of this movement to have a better healthcare system, better for us as patients and our families, and better for the expensive healthcare to keep our country afloat.
Dr. Bruce, I'm going to give you the last word. We have just 1 more minute before we wrap up. You're the father of this movement. How's it doing?
Yeah, Dad.
Is this at its toddler stage, or is it moving into adolescence, or is there a level of maturity now that you look back at and are really quite proud about?
Yeah, I think there's certainly, over the last 2 to 3 years, tremendous arc and increasing interest in the model. I get, a dozen cold calls a week from health systems and health system leaders who are just interested in learning more. So the interest is there, the entertainment needs to happen, culture change is starting, and, change is You know, we used to keep people, as Bruce was saying, deliveries, we used to keep people in the hospital with cataract surgery for a week. And we used to have hospitals filled with patients with long-term mental illness. We don't see those anymore. So big economic change can happen. I think it will happen here, but we do need leadership and we do need payment relief and evolution. But I think it will happen, and we hope to have you along for the ride.
Thank you very much. Please join me in thanking all the panel.